Thanks very much. So I've kind of changed I know the session was about babies, birth and beyond, and I'm kind of taking a step back and saying that we need to look at before, between and beyond pregnancy, because we really need to look at optimising reproductive health across the life course, which Michael has really made a very good case for. Thank you, Michael. So I am talking about women today, not that I don't think men are important. We know that the reproductive health of men is important for them, but also for babies and for intergenerational health. And I have 3 boys, so I do think it's important, but it's certainly not my area of expertise. So the picture of the life course. I'm feeling a bit like the little old lady on the end today because I was at a 21st last night and I was dancing with a whole lot of young things, and I think I've skipped 1 or 2 and really feeling my age today. I'd also like to acknowledge the traditional owners and pay my respects to elders past, present and emerging. So I'm going to talk about sexual and reproductive health, why it's important, how do we improve it, what some of the barriers are, and I'm going to just talk about some of the research that our team has been doing on 3 areas across the life course, so pregnancy planning and preconception health, weight gain prevention and polycystic ovary syndrome, and our group does quite a bit of work that interlinks with Michael's around that area. And also around what's the role of having a reproductive life plan? So sexual and reproductive health means that people are able to have a responsible, satisfying and safe sex life, the capability to reproduce and the freedom to decide if, when and how often that they want to do this. And to enable this we need implementation of education that reaches everyone, and we also need access to affordable sexual and reproductive medicine for everyone. And that includes safe, effective, affordable and acceptable methods of birth control. And we need to facilitate environments in healthcare that support individuals to reduce their risk and to promote healthy lifestyles so they can maximise their reproductive health and their overall health. So I don't really need to talk about this because Michael did such a beautiful job about how we can improve the health of men and women themselves across the lifespan, impact the health of their gametes and the intrauterine environment, pregnancy outcomes, and really importantly, that intergenerational health. And I think that we need to, there's 3 main areas where it can work. So we need to look at preventive health, we need to look at preconception, and we also need to look at contraception. And those will all be important at different phases in people's lives. So some of the barriers that women have reported that they experience in sexual and reproductive health is around health services. So do they actually exist where they live? What's the cost of it? Do they have access to a trusted healthcare provider? Do they provide culturally appropriate care? Is it youth friendly, for example? In rural areas they experience a lot of issues with shame and embarrassment. And is there flexibility? So young people in particular often prefer having drop-ins rather than appointments, for example. Women also report that they don't really understand what the role of primary health care is when it comes to things around preventive care or preconception care. They'll go for a contraception or a pap smear, but don't really think that it's necessarily GP's role or primary health care's role to talk to them, and they don't want to waste their time. Health literacy is really important, so their knowledge of how important all of this stuff is for their health and for the health of any future babies. People think that, having a baby naturally is quite normal, and do they actually need to think about it or plan for it? There's also issues around culture, so for some family planning is not really appropriate. And also attitude. So a lot of women are quite ambivalent often when it comes to their reproductive health or planning a pregnancy. And women with, for example, chronic disease are often quite fearful of discussing pregnancy planning and their reproductive and preconception health because it's quite scary often what they're actually being asked to do. Health providers also experience barriers. So again, some of them think that it's outside their role. And in terms of service design, it's often expensive for women, they feel that the health providers have competing priorities and short consultation times which don't really facilitate a discussion around reproductive health or beyond contraception and pap smears. They also find it difficult often because they don't have enough resources, both for themselves, such as checklists, or also for women, and particularly for women who don't have a lot of health literacy or knowledge around areas. It's very difficult when to start those conversations. And again, they're often a bit scared about talking to women because they don't want to alienate women and disengage them from healthcare when they start talking about obesity, for example, and smoking. So the things that we need to do to support sexual and reproductive health include education and engagement of community and health providers, access to care, supportive systems to help healthcare providers and community when guidelines and implementation, make it easy for those to be implemented. And we need some of those overarching principles of community input, because that's why things often don't work, because we don't really engage with community to work out what they want and why they want it and how. And we need to remember the social determinants of health. There's a really good book there if anyone is interested around social determinants of Indigenous health. And we have those layers around us that affect our health, so the individual lifestyle, our social and community networks, as well as that broader socioeconomic, cultural and environmental conditions. And we need to always remember to have that health equity lens, because we can't just treat everyone the same, because not everyone starts with the same opportunities. And I think importantly we need a life course approach. So I'm going to talk about 3 areas where we've been working around doing that. So one is around pregnancy planning and preconception health. So it's really important. So pregnancy planning, we know that 50 to 70% of women plan their pregnancy, and then there's a number that are completely unplanned and some that are unintended. We also know that about half of those women are using contraception, about a quarter of them are using the pill. But we know that when women have to make daily decisions about their contraception, they're much more likely to have an unplanned pregnancy. We also know that they don't tend to take up pap smears. We know that about 50 to 78% of women are having cervical screening, and that's also decreased in certain groups, such as those in lower socioeconomic groups and Aboriginal and Torres Strait Islander women and women in rural and remote areas. If we're going to look at impacting on things like obesity and smoking, and women who, for example, do have issues with fertility, such as PCOS, it's really important to diagnose those early and to have those conversations early. So some of the work that we're doing is looking at, in Australia, the London measure of unplanned pregnancy. This is a tool that was developed at the University College of London, and it's 6 questions. And it's been validated for use in a number of countries and continents. And we're doing a validation of that in the Australian context and piloting its use in routine maternity care. Because if you're going to look at implementing health promotion around preconception and pregnancy planning, you need to be able to measure your impact in some way. So if it was a tool that's quite easy to use in routine maternity care, then that would be one way to monitor that. We're also doing a survey of pregnancy planning, preconception health knowledge and behaviour, and health provider interactions in women who are giving birth at Monash Health over 12 months. And Monash has a really diverse group of women who give birth there. About 60% are born overseas. And the question's been developed with international colleagues based on previous validated tools, so we're hoping to compare our findings with what they've reported, and that's currently being administered. And we're also undertaking interviews and focus groups with women from a number of groups in Melbourne, but including those from culturally and linguistically diverse backgrounds. And overarching with all of this, we have community advisory groups which are helping us from the very conception of the research and following it right through. We've also had quite an exciting partnership that's happened with Medibank Private. So you would think that you are capturing a group of women that are probably the higher socioeconomic status group, but about half of women actually do take out private health insurance before they're planning a pregnancy. So it's quite hard to actually reach women and find out what they're thinking when they're actually planning a pregnancy. So they're kind of a group that are it's going to be really good for us to talk with and to work with. We're also, if you look at obesity and across the life course, so Michael's really talked about that quite a bit, and it's very difficult again once you come into pregnancy, if your BMI is overweight or obese, to do very much about it. You can work at limiting gestational weight gain, but really ideally we should be working with women before that happens. So we've had a program called the Healthy Lifestyle for Women program, and it's worked across a number of target groups, target settings, and across policy and strategies. And the Australian Longitudinal Women's Health Study has reported that women put on around 700 grams per year, which doesn't sound like a lot until you think about it, what that means over 10 years. And women also report that they retain about 2 to 3 kilograms of weight after each pregnancy. And that's higher in women who have a gestational weight gain, which is higher than the recommended international guidelines. So they're kind of areas where we've been focusing on. So the first place that this was tried, it's a social cognitive approach, and it basically helps. It's not prescriptive. It talks to women about what they currently do with their exercise and diet and lifestyle, and looks at making small achievable changes, and you monitor them. And if it hasn't worked, look at why not, and perhaps even make different goals. And so the first time that this was tried, Kate Lombard, who developed this, recruited women through 12 primary schools, so they were all women who had school-aged children, and they were either given an intervention or were just given, or the control group were given just general information about health and diet. So the other women were given 3 group sessions where they discussed lifestyle changes, and then they were followed up with text messages every month over the course of the year. So the women who had the intervention, so had the group sessions and the texts, they had a trend towards a decrease in weight, and the women in the other group had a trend to an increase in weight. But that wasn't really, the aim wasn't really to lose weight, it was really about weight gain prevention. And there certainly was a difference in the 2 groups in the overall weight change. The secondary outcomes included women feeling better able to manage their healthy eating and physical activity, and feeling more confident in controlling their weight. So again, it doesn't sound like a lot, but if you look at it on a population-based level, it actually has the potential to have quite a significant impact. The next place that this approach was then undertaken was in pregnancy at Monash Health. So 228 women were recruited at their booking visit, and they were given 4 one-on-one sessions around lifestyle management, and there was a decrease in gestational weight gain in the women that received that extra advice compared with the women who just got the routine advice. And the benefit, interestingly, was mostly in women who were overweight rather than women who started with a BMI greater than 35, and it's probably because it's just much harder for them and they need much more intensive intervention. But the interesting one was that it was actually also more beneficial for women from culturally and linguistically diverse backgrounds. And we think that some of that was because women would come in saying that their mother or their mother-in-law had told them that they needed to do this particular thing or eat this particular thing in pregnancy, or that they couldn't exercise. And there were a lot of cultural beliefs, and they often felt that they had the power to say, actually, it's okay for me to do this, having attended those sessions. And this program has now been adapted and implemented into what we're calling the Healthy Lifestyle Clinic in routine antenatal care at Monash Health. So women who have a BMI of greater than 30 kilograms per metre squared either come to the Healthy Lifestyle Clinic or they'll go to routine care, and they see an endocrinologist and a health coach in routine care. And so that's a cost-neutral approach that we're managing to implement that. So that's currently about to be evaluated both in terms of any difference in weight gain and also how women have found the process and how the staff have found it as well. It was a bit tricky to implement at first, but certainly from the staff point of view it's become much easier as time's gone on. And then finally it's been approached in rural communities. So the research group did many hours in the car driving all around Victoria and recruited 649 women from 41 communities. So the communities were randomised, women in the communities were randomised to either get the support or not. And again, there was a between group difference of not a large amount of weight, but enough that it does become significant over time. And there was quite broad reach across the towns. Women also reported that they thought it had a positive impact on health behaviours with the rest of their family. And the retention rates at 1 year were at 76%, and participants mostly said that they would recommend the program. So the other area that my group does a lot of work in is on polycystic ovary syndrome. So this is a syndrome that has had many different criteria over the years, but currently the one that most of us are working with is called the Rotterdam criteria, where you have 2 of 3 of these features, either raised androgens or excess hair growth, so hyperandrogenism, or irregular cycles and not ovulating frequently, or at all in fact, and polycystic ovaries on ultrasound. And it affects anywhere between 12 to 18% of women and is more common in Aboriginal and Torres Strait Islander women and is worse with obesity in terms of prevalence and also the features. That again has impacts across the life course. So for young women, they often present with irregular cycles, excess hair growth. There's an increase in anxiety, depression, body image disorders. Once you go into thinking about becoming pregnant, obviously that causes reduced fertility, and later in life, and in fact even in women who aren't that old, there's also increased risks in metabolic syndrome, diabetes, cardiovascular disease, and possibly some cancers. And again has impacts on both on the babies and then in the intergenerational. So with polycystic ovary syndrome, there's been studies that report that women experience significant delays to diagnosis and often have an incorrect diagnosis, and that's been multifactorial. Some of it's been about changing diagnostic criteria, and some of it is about lack of awareness, and also about women presenting late. But I think this one really highlights the importance of looking after women when they're young and helping them maximise their health. So of an international survey of about 1,500 women, about 45% said they'd seen 3 or more doctors before they got a diagnosis. Nearly a third had greater than 2 years to diagnosis, and only 35% were satisfied with the whole process, not surprisingly, given that. And they also reported that most of them were dissatisfied or indifferent to the information that they ended up being given by their healthcare providers. So it's not really very good as a healthcare provider. So some of the work that's been done is that national guidelines were developed and endorsed by the National Health and Medical Research Council in 2010. So these had quite clear diagnostic criteria, recommended screening for metabolic and mental health, management of infertility, and recommendations for lifestyle management and prevention of weight gain. There's been huge amounts of translation and dissemination, just like John's work. So we've been up to Cape York and Roma and the middle of New South Wales. I don't think we got over to Western Australia very much, though, I have to say. And a lot of work with both healthcare providers and community. And in fact, there's now international guidelines that are in the process of being developed now, so updating these ones, but with an international context. So it definitely has the potential for significant impact. But really, with all of that other work that was done around women, we felt that it was really important to explore some of that a bit further. So we surveyed 249 women with PCOS in Australia, from 18 to 45 years, but the majority were between 26 and 35. They were spread across metropolitan, rural and remote. The majority did have some post-school education. A small proportion were born overseas, but we did get a good response from Aboriginal and Torres Strait Islander women of 4%, and almost half had a diagnosis greater than 5 years and the remainder less than 5 years. So we asked them about different things, and one was about where they got the information and whether they were using electronic sources. And the other thing that we asked them was around something called a question prompt list, which is basically a list. It has information, it has lists of questions that you can take to facilitate your interaction with your healthcare provider. So the majority by far said that they would really like to have a question prompt list and that they would be likely to use it. We also then, so in terms of looking at developing one, we then asked them what they find difficult to talk to their health professionals about. So that would help inform what we then developed. So we then developed a question prompt list. So it has a page about what it is, who it's for. We have quite a lot of information around where you can find information about PCOS, because we don't want women just going in and asking their health provider everything. It gives them some evidence-based and good quality websites, for example, to look at before they go in. And there's some advice about how to use it with your health provider. There's a contents page. Then there is actually a list of questions, which are some are general and some are more specific around different topic areas. And we've done focus groups with women who have really taken this on board, and there were some really lovely things that we actually weren't really expecting, where women have said that they found it quite empowering. And one woman who said she'd had PCOS for over 10 years and there was stuff in there that she looked at and was like, oh, I didn't know I could do that, I didn't know about that. So we've done some pilot testing with health providers, which is a bit challenging. I'm a health provider, and I think I do find it a bit challenging sometimes when people walk in the room with their list of questions, and this is even more formalised. The women have really been quite positive so far. This has been with GPs. And the GPs, surprisingly, who actually thought that, I think the main fear was that it would make the consultation too long, but women are really encouraged to look at what's affecting them right now, what are their main priorities now, which is obviously going to change across your life course. And so actually they were surprised and said that actually it didn't really generally tend to make the consultation too long. So that's now being trialled with other health providers, gynecologists, endocrinologists, and we're planning to do a randomised controlled trial at a PCOS clinic that's starting at Monash Health. The other thing that we've done is looked at supporting women's health needs around information. So that same survey that we did was asking women about where they get their information and how they use it. And most women, not surprisingly, said that they'd used electronic devices to find information or to manage their PCOS, and for different things. So a lot of women are using fitness devices and things like that to monitor their physical activity and diet. And also to track menstrual cycles was another quite common one. Most women said that they would like an app rather than a website, and that they would really like a PCOS specific app if one was available. And most of them had said that the main reason that they hadn't was that there wasn't one to meet their needs, and we have reviewed the apps that are available and they're not very good quality. And not very comprehensive, so it's not surprising that they couldn't find one. So we've been having a lot of fun now developing an app for women with PCOS. So we have a draft that's now being about to undergo user testing and user experience testing, and then hoping to we'll be trialling that also at the clinic and then looking to launch that next year. But it's really great because it's quite interactive, so again really looks at linking women in at what's important at different stages of their life. They can individualise it and mark which things are important to them at the time, and that means that they will get targeted information relating to what their needs are now. We've also been involved in some models of care with polycystic ovary syndrome. So there's been 2 in community settings, One is based at Melbourne in Jean Hulls, which has an endocrinologist and a dietitian. And there was one in the Torres Strait that had a women's health nurse, a GP and a dietitian. And they both tend to use those principles again of that help her approach rather than the prescriptive dietary and physical activity advice. And as I said, there's one also about to start in Melbourne, which again is also going to be multidisciplinary. But in part of the evaluation that we did of the one in the Torres Strait, I think again it just highlights that issue that we've been talking about across the life course, that time and again we hear from women with PCOS that, you know, we really need to inform high school girls about this so they can get diagnosed earlier, and women who said, if I was informed and had the knowledge earlier, I could have made better life choices. For one at that time, if I dealt with PCOS back then, my pregnancy journey would have been better. So that was from someone who was undergoing IVF treatment. So in conclusion, I think that everyone should have a reproductive life plan. How do we go about that? That's a little bit more tricky. There are tools that have been used across, mostly in the United States. But the main message is that we should be thinking about reproductive life plans with every woman, every time, and changing pregnancy from chance to choice. And just referring back to what I was saying earlier about the importance of men, it probably should really be every person, every time. Thank you.